Welcome to Drugs for the Skin. This is a bit longer of a presentation. I do not expect you to know strengths and dosages, but I do expect for you to be able to recognize some of the common drugs mentioned in this presentation, along with their actions and indications. I also expect you to remember some of the anomalies. For example, fluconazole cannot be administered to pregnant women due to risk of miscarriage. There are many different topical dosage forms available on the market. Some medications are available in several different forms. The choice of topical product often depends on the condition of the skin being treated, the location of the affected area, cost, and patient preference. Choosing the right formulation for a patient based on their needs and preferences could improve adherence and potentially prevent a premature progression to oral systemic therapies for certain conditions. Okay, here we're looking at creams. Creams are an oil and water emulsion. They are not as thick as ointments, but they are thicker than lotions. Creams tend to be good for most skin types, including dry, sensitive skin. They do moisturize, but not as much as ointments. Because they provide no occlusion, they can be used over exudates. Ointments are thick, greasy preparations with an oil or petroleum jelly base. They provide the highest medication absorption of all formulations. The enhanced penetration makes it especially useful in management of conditions with thickened skin. For example, lichenification secondary to prolonged scratching or inflamed skin. Because it is occlusive, it is not a good choice for weeping or oozing skin conditions or in areas prone to heavy perspiration. It is an excellent choice for dry skin conditions. Pastes are mixtures of an ointment and a powder. The addition of a powder increases adherence to the skin, which makes it hard to wash off. The powder disrupts the occlusive nature of an ointment, allowing for air to reach the covered skin while still providing a protective barrier. Lotions are water-based, but some may contain alcohol or acids and very little oil, if any. These are good forms for oily skin. Lotions are non-greasy, which tends to promote more patient satisfaction. Other advantages of lotions is that they are easy to spread and quick drying, which makes them a good choice for large areas or for hairy areas and intertriginous areas that are prone to chafing. Unlike ointments and creams, they are suitable for oily skin. They can also be used on the face. Foams are aerated solutions. They are non-greasy and they spread easily, dry quickly, and leave minimal residue. They tend to be good choices for faces, sensitive skin, oily skin, and hairy areas. Gels are transparent preparations. Because they liquefy on skin contact, they often have a cooling effect as they dry. Because they are non-greasy and tend to have a drying effect, gels are good choices for oily skin. They spread easily, so they are good for covering large or hairy areas. Because they dry clear and invisible, they may be more acceptable for facial regions. These are other dosage forms that are less commonly used. Sprays are easy to use on large areas. Liquids have minimal use. Most powders have a talc or cornstarch base. They are dry with a silky feel that reduces friction between the surfaces. This can make them useful between skin folds. The dryness of the vehicle can be helpful when applied to regions that tend to perspire, such as the feet or the axilla. Topical corticosteroids are used to relieve inflammation and itching. They are most commonly used as creams or ointments. Ointments are better absorbed than creams. Be aware the dosage form can impact drug absorption. For example, betamethasone dipropionate 0.05% lotion is medium potency. The augmented cream is high potency, and the augmented ointment is very high potency. Please review the handout on topical corticosteroids. They are classified as to their potency by their vasoconstrictive ability. Classification can vary depending on the resource checked, especially in the medium and high range. For practice, I would learn a couple of formulations in each category and use them consistently. I usually go by cost. For a low potency steroid, stick with hydrocortisone 0.5% to 2.5% cream. It costs as little as $2 for 30 grams. The hydrocortisone preparations that are over the counter are 0.5 to 1%. Many of the prescription creams are still only cost about $3. Use GoodRx and look them up. For medium potency steroid, triamcinolone cream or ointment only costs about $5 for 30 grams. Or consider fluticasone propionate cream at $20 for 30 grams. If a high potency steroid is needed, think of augmented betamethasone dipropionate cream for about $20 for 15 grams. For very high potency, considered augmented betamethasone ointment, but it is $100 for 45 grams. For testing purposes, I will give you the potency level. You do not need to know the specifics of each drug. You need to know this table. Use the lowest formulation that is effective. Very high potency steroids can only be used on adults and a very limited area. They are especially good for thick lesions or lesions on the palms of the hand, soles of the feet, and scalp. The indications for high potency topical corticosteroids are the same. Moderate potency topical corticosteroids can be used for more extensive areas of skin. In addition to adults, low potency topical corticosteroids are recommended for the elderly, children, and infants. These are the only ones that can be applied to the face, genitals, and intertriginous zones of the body. Some sources say low potency topical corticosteroids may be used around the eyes sparingly, while other sources say they should not be used and systemic treatment is needed. There are both local and systemic adverse effects. The local adverse effects include the development of atrophy, stry, and purpura. Topical corticosteroids can increase or cause acne, perioral dermatitis, hypopigmentation, and a rash. The others listed are not as common. The systemic adverse effects may include growth suppression in children and adrenal suppression. Infants are at the highest risk. The risk of systemic adverse effects increases when large surface areas of skin are treated. Once or twice daily dosing is generally recommended. For psoriasis, some experts start with BID dosing, then taper as the disease responds. Once daily dosing of medium to very high potency agents helps minimize side effects. Even less frequency dosing, such as weekends only, may be appropriate for chronic conditions such as psoriasis or eczema once the disease is under control. Very potent formulations should be used for short periods of time, 14 to 28 days, or intermittently to reduce side effects. Laboratory tests for adrenal suppression may be required after long periods of therapy or treatment of large areas. It is recommended that patients on very high potency steroids not be discontinued abruptly, but instead switch to a lower potency agent to prevent a rebound phenomenon. Corticosteroids should not be used on ulcerated or open sores or atrophic skin. When deciding on the quantity, consider that about 0.5 grams covers an entire area the size of both hands of an adult with the fingers together. This is the classification of acne, which ultimately determines the treatment. There are multiple ways to classify acne, and there isn't any evidence to prefer one classification over another. I chose this classification as it matches the treatment categories of mild, moderate, and severe. This is the summary of the guidelines of care for the management of acne vulgaris 2015 from the American Academy of Dermatology. We are going to go over each category on separate slides. For more mild acne, topical retinoids, which are vitamin A derivatives, are appropriate. They include tretinoin, adapalene, and tazarotene. All of them are available via prescription only, except for adapalene, which launched lower doses over the counter a couple of years ago under the brand name Differin, which it's Differin 0.1%. Proactive also contains adapalene. Retinoids increase cell turnover and work on acne by decreasing inflammation and unclogging pores. These topical medications are considered the core of topical therapy, and usually keratolytic agents are used first, so the bottom ones are used first. Both of these agents are applied to the clean skin once daily, usually before bedtime. Side effects include erythema, dryness, and sun sensitivity. Patients should be warned that acne may worsen before the skin clears. Purging happens when several new lesions pop up to the surface of the skin upon starting a new regimen. Treatments like retinoids or antibiotics can lyse what's in the pores and speed skin cell turnover, bringing all that debris to the surface more quickly where it presents as new pustules. Then, theoretically, the patient is left with pores that are no longer a media for infections and inflammation. But in the beginning of a new treatment, it can feel like a minefield. Patients should continue to use a non-comedogenic moisturizer and sunblock. There are keratolytic agents like salicylic acid, which comes in many formulations, and glycolic acid, which is usually in pads or toners. These are exfoliants that soften, separate, and cause desquamation of the cornified epithelium or horny layer of the skin that often clogs pores. Then there's benzoyl peroxide, which breaks up the debris in clogged pores and inhibits bacterial growth and inflammation. One of these are the initial therapy for mild acne. Benzoyl peroxide is almost always used first. Moderate acne. Several topical agents are available to decrease Proponium bacterium acnes proliferation, that's the bacteria that causes acne, and inhibit the production of inflammatory mediators. Moderate acne is treated with combination topical therapy such as benzoyl peroxide and a retinoid, or a retinoid and benzoyl peroxide with an antibiotic, or benzoyl peroxide and a retinoid with antibiotic. I'm not very familiar with the third combination. Topical antibiotics are not recommended in monotherapy. Combinations with antibiotics makes the antibiotic work better and decreases the chance of resistance. There are combination products with benzoyl peroxide and erythromycin or clindamycin. These are usually applied once or twice a day after cleansing. Oral antibiotics are effective in treating inflammatory acne by decreasing the P. acnes, the bacteria, and reducing the concentration of free fatty acids, thereby inhibiting comedogenesis. Oral antibiotics are reserved for more severe cases, lesions unresponsive to topical therapy, patients at risk for scarring, and lesions on the trunk or back. Minocycline is best. They should always be using a retinoid and benzoyl peroxide also. Okay, treatment for severe acne. Topical preparations are prescribed, as with the previous slide, usually a retinoid and benzoyl peroxide. Oral antibiotics are also given. What's different is isotretinoin. Isotretinoin is teratogenic and not prescribed in primary care, but you may have patients on it. It decreases the size of the sebaceous gland, can cause bone pain and depression. They must stay out of the sun. They are on it for 5 months, off for 2. Accutane, which is the brand name, isn't produced anymore, but generic isotretinoin is still available. Obviously, other treatments are tried first. There are a couple of hormonal treatments for acne. 4 combination oral contraceptives, the Estrostep, orthotricycline, Bayaz, and Yaz, are approved for managing acne in women. Treatments limited to females at least 15 years of age who want contraception, have reached menarche, and have not responded to topical drugs. Benefits are due primarily to the estrogen in combination oral contraceptives, not the progestin. Birth control pills suppress ovarian androgen production and increase production of a protein that binds androgens and thereby makes them inactive. As a rule, spironolactone is added to the regimen after an oral contraceptive has proved inadequate. This sequence makes sense because spironolactone is teratogenic, and hence contraception should be implemented before taking the drug. Personally, I have prescribed oral contraceptives for acne, but not spironolactone. Now on to psoriasis. For most patients with milder psoriasis, start with topicals, such as moisturizers, corticosteroids, and calcipotriene. Use corticosteroids as the first line of therapy for mild to moderate psoriasis, nail psoriasis, and scalp psoriasis. They may also be used as an adjunct for more severe or resistant disease. The efficacy of corticosteroids increases as potency increases, but then you have the risk of side effects increasing with increasing potency and duration of use. Limit the use of a very high potency agent to 2 to 4 weeks. For scalp psoriasis, consider a foam, shampoo, or solution. Use lower potency agents on the face or thin-skinned areas, and reserve potent agents for thick plaques. Some experts start with twice daily dosing, then taper. Calcipotriene is a vitamin D3 analog. It's available as a solution or as a combo product with betamethasone in a suspension. It is used as first-line treatment for mild psoriasis, nail psoriasis, palmoplantar psoriasis, and scalp psoriasis. The combo product can be used for moderate to severe disease. Calcipotriene, I have trouble pronouncing that, can be combined with a topical steroid or alternated with a topical steroid or combo to improve efficacy and reduce side effects. It is applied twice a day daily as monotherapy or once daily in the morning with a steroid in the evening. Calcitriol ointment is somewhat similar and efficacious to calcipotriene. Tazarotene is used for mild plaque psoriasis. It is second-line treatment for nail psoriasis. It is recommended to be used with a topical corticosteroid to reduce side effects, such as irritation or atrophy, and improve efficacy. It has a slower onset than topical corticosteroids, and it may not be as well tolerated as topical corticosteroids or vitamin D analogs. About 20% of patients have moderate to severe disease and may also need systemic drugs. Methotrexate is used for psoriasis that is too severe, refractory, or extensive for topicals, and that would include severe disease of the palm, sole, or scalp, involvement of 10% or more of body surface area. Methotrexate is a cheaper alternative to biologics. It is not as effective as many of the biologics and cyclosporine. It requires monitoring of the liver function due to hepatotoxicity. Nausea is common. Methotrexate is also teratogenic. Women should use effective contraception during use and for at least one menstrual cycle post-discontinuation. Men should use contraception during use and for at least 3 months post-discontinuation. It is administered weekly and not daily. Okay, cyclosporine. Indications for cyclosporine are similar to methotrexate, but it can also be considered for severe or refractory nail involvement. It is better tolerated than methotrexate. The risk of nephrotoxicity and skin cancer increases with duration of use. The patient's renal function, blood pressure, triglycerides all need to be monitored. Cyclosporine can be used for up to 2 years, but is usually used intermittently for up to 12 weeks at a time to limit the risks of irreversible kidney damage and hypertension. I am going to discuss biologic agents as a group. They are changing frequently. You can expect biologics to continue to gain popularity. They tend to work better and are better tolerated than other systemic meds. As of now, I do not prescribe these agents, but have many patients on them, though, through a dermatologist. With biologics, you need to balance efficacy, safety, and cost. The newer biologics seem to work better than the older ones, but don't have a long safety record yet. For example, one more patient will have clear or nearly clear skin for every 5 treated with a new drug called Silic versus Stelara, which is older, for 12 weeks. But Silic has a warning about suicide. You'll need to register with the manufacturer and follow specific requirements to prescribe it. Generally, think of Humira or Stelara first when a biologic is needed for psoriasis, and save newer meds for patients who don't respond well to the other options. Be aware that Silic costs about $3,500 a month versus $5,000 for Enbrel, Humira, and Tremefa, and up to $7,000 for Stelara. Look for drug-disease interactions. Biologics may cause or worsen some conditions. For example, heart failure and multiple sclerosis are linked to tumor necrosis factor alpha blockers, such as Humira and Enbrel and Remicade. An inflammatory bowel disease is associated with interleukin-17A blockers, so the Silic, Taltz, and Cosentyx. These are all brand names, by the way. I couldn't spit out all of the monoclonal antibodies. Reduce risks. Ensure vaccines are up to date before starting a biologic. Avoid live vaccines, the MMR, in patients on a biologic, but it's okay to give inactivated vaccines, the flu shots, Tdap, those sorts. Warn about infection risk. Tell patients to promptly contact your office for fever, malaise, etc., and alert staff about biologic use. To minimize injection site reactions, suggest letting the meds warm to room temperature before use and rotate injection sites. Now we're on to eczema. Topical steroids are the foundation of anti-inflammatory therapy for eczema. Steroids inhibit the release of inflammatory cytokines, reducing the rash and itch of eczema. Various steroid potencies are used to treat eczema. When used chronically for prevention, use the smallest amount of the lowest potency steroid to limit exposure and adverse effects. To treat flares, use a thin layer once or twice daily on the affected areas based on the product and response. To prevent flares, use a thin layer once or twice a week or up to twice daily depending on the potency of the steroid. Apply to the most commonly affected areas. Calcineurin inhibitors reduce inflammation by blocking the production of inflammatory cytokines. Use a calcineurin inhibitor when steroids can't be used. For example, if they have sensitive skin, or it's on the face and genital area, or they're not tolerating a steroid. To prevent flares, use a thin layer 2 or 3 times per week. To treat flares, not clearing with topical steroids alone, use a thin layer daily. Pimecrolimus is approved for use in adults and children 2 years of age and older. Adverse effects can include localized burning and itching, especially when applied during flares. Pre-treatment with a topical steroid may minimize these effects. Inform patients of the theoretical risk of malignancy, it's skin cancer and lymphoma, and the limited possibility of viral skin infections with the calcineurin inhibitor use. The labeling warns of cancer risks, but rare cases have been reported and causation has not yet been determined. PDE4 inhibitors reduce inflammation by inhibiting the phosphodiesterase 4 enzyme. Use a thin layer twice daily for mild to moderate eczema to prevent or treat flares when steroids can't be used. Crisaborole is approved for use in adults and children 2 years of age and older. Dupilumab is an interleukin-4 receptor alpha antagonist that inhibits interleukin-4 and interleukin-13, 2 of the key inflammatory cytokines of eczema. It is used for moderate to severe eczema in adults when other therapies aren't adequate or can't be used. It can be used with or without topical steroids. This is a sub-Q injection, so you administer an initial dose of 2 300 milligrams subcutaneous injections using 2 different sites. Then give 300 milligrams every other week. Adverse effects can include injection site reactions, conjunctivitis, and oral herpes infection. I've kind of wondered why only oral herpes, why it wouldn't be any type of herpes, but it specifically says oral herpes. The common wart is Verruca vulgaris, and they consist of hard, rough, horny papules. Plantar warts are Verruca plantaris. These warts are on the bottom of the feet and are rough and hard, but may be painful upon walking. Common warts are caused by 3 types of HPV: HPV-1, HPV-2, and HPV-3. Plantar warts are most commonly caused by HPV-1, but other HPV viruses too. Warts can be physically removed by multiple modalities. I would like to emphasize cryotherapy as the most reliable and easy method. There are topical drugs, with salicylic acid being the most common. The patient would do this at home by first soaking the wart for 5 minutes before applying the acid, and this is repeated daily. Others are listed, but I stick to cryotherapy. This can also be done over the counter. Drugs for seborrheic dermatitis. First-line therapy is topical antifungals or topical corticosteroids. Both reduce the inflammatory response. Topical antifungals reduce Malassezia proliferation, which is a fungus, and the subsequent inflammation it causes. For the face, trunk, and other areas, ketoconazole 2% cream and metronidazole 0.75% gel, among several others, have been shown to be effective at clearing symptoms. If this intervention does not help, a mild topical steroid such as 1% or 2.5% hydrocortisone can still be used daily until the eruption clears. For hair, anti-seborrheic shampoos such as ketoconazole 2%, 2% is by prescription only. There is 1% that's over the counter. Selenium sulfide 2.5%, which is Selsun Blue, and again the 2.5% is by prescription and 1% is over the counter. Cycloparox 1%, which is Loprox, it's prescription only. Apply these shampoos 1 to 2 times a week for 4 weeks, and then it may be used to treat flare-ups and prevent relapses also. Ketoconazole 2% topical has the most evidence for effectiveness among the antifungals. The shampoos may be used on the skin too. Some patients may require a topical steroid in the form of a lotion, solution, or form applied once a day after washing with an anti-seborrheic shampoo. Impetigo is the most common bacterial infection of the skin, usually in children 2 to 5 years old. The most common bacteria is Staphylococcus aureus. The 3 topicals listed are all antibiotics. For severe infections, oral antibiotics may be given as listed. Dermatophyte infections are named according to their location. Tinea capitis is the infection of the head or scalp. It's usually seen as a patchy, scaly areas of hair loss, but may become more inflamed and pustular. It may be in an annular ring. That's why they tend to call it ringworm. Tinea corporis is the infection of the body. It appears on skin as erythematous plaques and papules in an annular or arciform pattern. Lesions often have slightly elevated borders with central clearing. Tinea cruris is commonly called jock itch. It appears on the groin and upper inner thigh and extends to the gluteal folds as erythematous scaling patches with raised borders. The scrotum and penis usually aren't involved. Tinea pedis is commonly called athlete's foot. It can occur as interdigital scaling, maceration, and fissuring. It can also appear as a mild erythematous scaling that involves the sole and sides of the foot in a moccasin distribution. Tinea unguium is the infection of the nail. It's also called onychomycosis. The infection begins in the distal nail bed and spreads to infect the nail plate, causing the nail to appear thickened and yellowed with subungual keratinous debris. Interestingly, the nails look similar to patients who have peripheral vascular disease. Candidiasis is a fungus usually caused by Candida albicans, but there are other Candida organisms too. The non-candidemia infections, meaning not in the bloodstream, that are seen in primary care are usually oropharyngeal, thrush, vulvovaginal, and intertriginous. I see a lot of fungal infections in my practice. Tinea versicolor is a chronic, asymptomatic, and superficial fungal infection. The only sign is hypo or hyperpigmented spots, usually on the trunk and upper arms, but could be anywhere. The fungus is usually Malassezia. This is a summarization of the antifungal options. I have a copy of this in my little book I have at my work, so you might want to print this. Be sure to look at the additional 2 charts and your required readings from prescriber's letter. For the candidiasis one, only look at thrush and vulvovaginitis and not candidemia. I think I have too many DIs in there. On this chart, I did not mark ketoconazole as oral, as it is very hepatotoxic. Also know that the systemic azoles, including the single 150 milligram doses of fluconazole, should be avoided during pregnancy due to potential for increased risk of miscarriage. And last but not least, shingles. Treatment for shingles or herpes zoster should be started within 72 hours of rash onset. Treating early relieves symptoms, speeds resolution, and prevents or mitigates the development of post-herpetic neuralgia. The 3 main antivirals used to treat shingles are valacyclovir, which is 1,000 milligrams PO/TID for 7 days, famciclovir, 500 milligrams TID for 7 days, or acyclovir, 800 milligrams Q4 hours, or 5 doses daily for 7 days. So guess which one I wouldn't do, although acyclovir is the cheapest. For the severe herpetic pain, acetaminophen and NSAIDs are recommended. In addition, amitriptyline, a tricyclic antidepressant, can be continued for 90 days to help reduce post-hepatic neuralgia incidence and duration. A lidocaine patch can be applied over the painful areas with a limit of 3 patches simultaneously for up to 12 hours. Gabapentin can also be used for pain. Capsaicin cream may be a useful adjunct. Capsaicin cream is actually hot pepper juice and burns. I've never had any success with it. The Shingrix vaccine is recommended by the CDC for patients 50 years of age and older to prevent shingles and related complications. Shingrix is recommended for adults who previously received Zostavax and is the preferred vaccine now. Thank you for your time and attention.